Good afternoon, everyone. We're delighted to welcome you to today's webinar on billing Medicaid for eligible inpatient care of individuals who are incarcerated. I'm Fred Osher, the Director of Health Systems and Services Policy at the Council of State Governments Justice Center, and I'll briefly review the agenda for today's webinar and introduce our speakers in a moment. But first, I'd like to introduce you a bit to the webinar, to the Justice Center. As you know, the Justice Center is a national nonprofit organization that serves policymakers at the local, state, and federal level from all branches of government. We strive to provide practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen our communities. Our work is focused on reentry, responses to justice-involved individuals with mental illnesses, and justice reinvestment. As part of this work, the Justice Center provides technical assistance to the Justice and Mental Health Collaboration Project and Second Chance Act grantees and coordinates the National Reentry Resource Center. All of this is done in partnership and with support from the Bureau of Justice Assistance of the U.S. Department of Justice. Established by the Second Chance Act, the National Reentry Resource Center provides education, training, and technical assistance to states, tribes, territories, local governments, service providers, nonprofit organizations, and correction institutions working on prisoner reentry. The online resource can be accessed at www.csgjusticecenter.org/NRRC, as you can see on this slide. And it includes publications, news updates, webinars, and other resources designed to promote effective reentry practices. It also includes What Works in Reentry Clearinghouse, which is a database of evidence-based practices for reentry. We encourage you to visit the NRRC, where we recently added new pages devoted to information and resources on health and health policy issues, including a helpful list of federal resources and guidance on recent health policy changes. Today's presentations will be given by Gabrielle Delagarniere of the Legal Action Center, William Appel of North Carolina Division of Medical Assistance, Terry Catlett and Larry Huggins of the North Carolina Department of Public Safety. Gabrielle Delagarniere will start things off with an overview of federal law and applicable uses of federal Medicaid funds for incarcerated individuals. In this discussion, she'll cover how keeping individuals enrolled in Medicaid during their period of incarceration can lead to reductions in health spending for departments of correction, regardless of whether a state has opted to expand its Medicaid program as allowed under the Affordable Care Act. To close, Gabrielle will provide a few examples of states that have already taken advantage of this innovative healthcare financing approach. Terry Catlett, Larry Huggins, and Bill Appel will follow with a joint presentation of North Carolina's efforts to achieve cost savings using Medicaid billing for eligible inpatient care. We'll discuss the legislative foundation for the program, the ongoing collaboration between the Department of Public Safety and the Department of Health and Human Services, the successes they've achieved thus far, and some of the ongoing challenges that they confront. Lastly, we reserve time at the end of today's schedule for questions and answers. To submit a question at any point during the webinar, please type your question into the Q&A panel at the bottom right-hand portion of your screen. We'll keep a running list of content-related questions that we receive, and then ask the panelists to respond to the questions during the last segment of the webinar. We'll do our best to get through as many questions as possible. If you encounter technical or audio problems during the webinar, please contact WebEx technical support. The number is on this slide at the bottom, 1-866-229-3239. Today's webinar focuses on how states can take advantage of federal Medicaid funds to reduce corrections healthcare spending. A significant portion of the prison and jail population in states around the country is likely eligible for Medicaid, either through previously existing categorical or newly implemented income-based criteria. However, federal law prohibits states from using federal Medicaid funds to pay for care provided to incarcerated individuals in most circumstances, even if they're eligible or enrolled in insurance programs. This is commonly known as the inmate exclusion provision. Our discussion today focuses on critical exception to this rule that allows federal Medicaid funding to be used to finance care provided to eligible incarcerated individuals when those individuals are patients in medical institutions. The U.S. Department of Health and Human Services has clarified that a medical institution means a hospital or a nursing facility or a juvenile psychiatric facility or intermediate care facility, and that individuals to be eligible for reimbursement must be in an institution like this for at least 24 hours. Our speakers today will explain and clarify this issue and provide a practical example of how this opportunity can be leveraged to provide budgetary relief to corrections departments regardless of whether the state has decided to expand their Medicaid program. The discussion will focus on both the challenges encountered around this implementation and the necessary cross-agency collaboration. Now, I'd like to formally introduce our first presenter this afternoon, Gabrielle de la Gueriniere, who leads the Legal Action Center's federal policy advocacy to expand and improve health responses to drug and alcohol addiction and to end discrimination against people with drug and alcohol histories with criminal records. Gabrielle currently works with the United States Congress and this administration to increase funding for drug and alcohol prevention, treatment, recovery, and research programming. Also to ensure that the federal health care reform law is implemented well for people with addiction and mental health service needs, and to eliminate legal and policy barriers faced by people with criminal records and drug addiction histories. Gabrielle coordinates and helps to direct strategies for the Coalition for Whole Health, a coalition of national education and mental health organizations. She joined the Legal Action Center's Washington, D.C. office in 2003 after serving in various policy positions at the center. She became Director for National Policy in 2008. Gabrielle holds a BA from Boston University and a JD from American University's Washington College of Law. And without further delay, I will turn things over to you, Gabrielle.
Great. Thank you very much, Dr. Osher, and really appreciate all of your help in putting this together and your team. So very good to be with all of you today. I'm just going to advance the slide. There we go. So as Dr. Osher just mentioned, Legal Action Center is a 40-year-old nonprofit law and policy organization, and our focus is on law and policy related to people with drug and alcohol addiction histories, also mental health conditions, people involved in the criminal justice system, and people with HIV and AIDS. We do have support from the Bureau of Justice Assistance to support a number of BJA's grantees related to health reform and the criminal justice system. So very pleased, again, to be here with all of you today. As Dr. Osher mentioned, we also coordinate the Coalition for Whole Health, which is really focused on, again, the mental health and substance use disorder provisions of the healthcare reform law and ensuring that individuals with those needs are getting what they need. So as Dr. Osher mentioned, I'll be focusing on just a quick overview of how Medicaid works and then have some focused discussion on the inpatient exclusion provision of Medicaid and what this means. And as Dr. Osher mentioned, this is important for folks who are in states that have expanded their Medicaid population through the Affordable Care Act and those who have not. And this is really an underutilized provision that we think due in large part, as you all know much better than I do, the huge healthcare needs, the complex healthcare needs of the criminal justice involved population, and knowing just how much money states and localities have spent on care, knowing that there are opportunities for some additional federal funding hopefully will be helpful in helping these individuals, again, have their complex healthcare needs be met in a better way. And yes, I will move on right to the content. So a little more, again, about Medicaid. As we all know, the Medicaid program is really a state-federal partnership. There are broad guidelines that are set out in statute and federal statute and also through the agency that sets Medicaid policy, CMS, Centers for Medicare and Medicaid Services. States have a huge amount of flexibility to really design their programs in the way that makes sense for their population and the needs of their population. States and the federal government also share financing responsibilities through the Medicaid program. Eligibility for Medicaid has traditionally been based on income and then also on a number of different categorical definitions, including population group, whether the person is a child, a pregnant woman, a parent, or whether the person is a resident, where the person is a resident, and whether the person is a U.S. citizen. As we all know, with the Affordable Care Act, in states that have determined to expand their Medicaid population, they have both allowed higher income parents to be eligible for Medicaid, and they also have removed a number of these categorical restrictions and no longer require that the person be a custodial parent to be eligible for Medicaid. There's much more focus on, again, that income level. We'll go through a few kind of myths and misunderstandings about Medicaid and criminal justice involved people, but we'll just state at the outset that, again, involvement in the criminal justice system, whether it's in the past or currently, does not affect an individual's eligibility for Medicaid. And we'll be very sensitive to words when we talk about eligibility for Medicaid, that we are talking differently about federal funds being able to pay for services for a person who's incarcerated, which again will be a big part of my next few slides. So again, as I mentioned, federal government and states share Medicaid responsibility. The federal share is called the FMAP, the Federal Medical Assistance Percentage. And the amount of federal share for Medicaid services around the country varies state by state, but generally is about 50 to 73%. We know that through the Affordable Care Act, in states that have determined to move forward and expand their Medicaid population, the federal share does go up substantially. For the first few years, it's 100% federal dollars for those newly eligible individuals, and it never goes below a 90% share of federal cost payment for those, again, newly eligible individuals. In addition, for administrative costs, and I'll come back to this a little bit later, the federal government does pay at least half of those costs. So, eligibility for the Medicaid, for the criminal justice involved population, again, acknowledging that many people in the criminal justice system have had poor coverage for health care, have had poor access to health care, often have complex co-occurring chronic health conditions, and again, have great needs, which are quite costly often because people are quite ill by the time they reach health care often. The Medicaid expansion does really represent a huge opportunity for the criminal justice involved population. The additional federal funds, again, a 90% share after these first few years, really does represent huge money that could come into states and localities. As I mentioned earlier, involvement in the criminal justice system, whether past or present, doesn't have any kind of bearing on Medicaid eligibility or enrollment in Medicaid. However, there are restrictions, again, which we'll focus on, for services for people who are incarcerated. So the inmate exclusion provision in Medicaid does prohibit federal Medicaid dollars to pay for care for people who are in prisons, jails, detention facilities, and other types of penal facilities. So again, this is not about enrollment. It's not about eligibility for Medicaid. It's really about federal dollars, a prohibition for federal Medicaid dollars to pay for care provided to people who are incarcerated most of the time. But, and here is the underutilized exception, which has been a part of Medicaid law for many years, but for a variety of reasons really has been underutilized. There is an exception for people who are incarcerated who are receiving care. And as Dr. Osher mentioned earlier, there are a few different requirements here. So if a person is incarcerated and is ill enough that they must receive inpatient care, again, it must be inpatient, it cannot be outpatient services, and it has to be provided in a community-based facility. It cannot be a hospital that's a part of that prison, but an inpatient facility in a community-based hospital, nursing facility, juvenile psychiatric facility, or an intermediate care facility for at least 24 hours, federal funds can pay for those services. So again, it's very specific and very clear that under those circumstances, federal Medicaid dollars can pay for that incarcerated individual's care. And that really includes all medically necessary services that are covered by Medicaid in that state. And again, federal Medicaid dollars can pay for that care. So most states, when we look at why this is underutilized, one of the reasons is that most states terminate Medicaid eligibility when a person becomes incarcerated. But we know that a number of states, and I'm very much looking forward to hearing from the North Carolina folks about how they have done this, have really appreciated the cost savings that could come by ensuring that Medicaid is in a suspended, Medicaid enrollment is in some kind of suspended status rather than terminating Medicaid, which really does create a lot of problems. So a number of states, again, because of this inpatient care exclusion, have appreciated dollars that they were using state and local money to pay for inpatient community-based care for an individual who needed that care for more than 24 hours. So again, you see some of the examples here. North Carolina, who again we'll hear a lot more from later, saved $10 million in the first year they did this. California saved $31 million in the 2013 fiscal year, and New York estimated that it could save up to $20 million each year if they billed for the federal government for eligible inpatient care. So these are really substantial savings that have been projected. And again, for those states that have determined to expand their Medicaid population, because of the enhanced federal share, this really does represent an even greater opportunity for those states. So as I mentioned before, if a person is in a state where Medicaid eligibility is terminated, they are taken off the rolls, and there is often a delay when the person has to be redetermined to be eligible for Medicaid, and that has implications for the community care exception, which we talked about again, which federal dollars could pay for in those limited instances. And it also has huge implications for individuals as they transition back into the community from incarceration and need to continue to have access to health care services and medications to help them manage their illnesses. So these are tremendously important opportunities here. And a number of states have done things differently. Some states have chosen to suspend a person's Medicaid eligibility when they become incarcerated, and they then, when they are eligible for release at discharge, they work to determine that that person is still eligible for Medicaid, and they can get that Medicaid reactivated. In other states like New York, they indefinitely suspend Medicaid, so it is just in this constant state of suspension. So again, different states have done things a little bit differently. And as you might all imagine, it really involves a lot of work to align different IT systems, knowing that this involves a lot of claiming databases and other types of computer systems to ensure that there is the capability to suspend and to allow that person again who is eligible to reactivate and to be currently eligible again. So as I mentioned, Medicaid can be suspended during a person's incarceration. There is no prohibition on the person being enrolled in Medicaid. There only is a prohibition on those federal dollars paying for services for the individual while they're incarcerated, again, except for that inpatient exclusion provision. The federal government has actually encouraged states to suspend, not terminate Medicaid. And this has been, again, another kind of point of confusion, given that there's been a lot of miscommunication and kind of lack of understanding about how Medicaid and incarcerated populations kind of works. And so, again, the federal government has been really clear that they want Medicaid to be suspended, not terminated during a person's incarceration. There also is no federal prohibition against screening for an individual's Medicaid eligibility while that person is incarcerated. And HHS has actually clarified that Corrections Department employees can serve as authorized representatives of incarcerated people to help submit a Medicaid application on that person's behalf. So this really does emphasize, again, that enrollment can and should happen at all stages of involvement in the criminal justice system. One example I mentioned earlier, that New York has chosen to rework their system in a way that people are suspended indefinitely in their Medicaid eligibility is suspended indefinitely, and they are reinstated when they are discharged back into the community or when the person, again, goes into community-based inpatient care in the way that we discussed earlier. This does eliminate the need for that person to apply or reapply for Medicaid when they're released and does really help with that continuity of coverage piece and again, also with the continuity of care and access to continued care and supports when that person leaves incarceration. In New York, there are over 10,000 people who are currently in that suspended status who are incarcerated. So as I mentioned, again, huge opportunities here to align systems to really ensure that people have good coverage for health care and access to health care, particularly, again, in that critically important time when people are just released from incarceration into the community, to ensure that they have coverage, that isn't interrupted, and that they can continue to seek care and supports and medications in the community. As I mentioned, Medicaid, again, can really be used, federal Medicaid dollars can be used for inpatient community-based care. Again, if that person is admitted to a community-based hospital, a nursing home, a psychiatric facility, a juvenile psychiatric facility, or an intermediate care facility for 24 hours. And again, for states that have expanded their Medicaid population, the enhanced federal share does mean that the federal government will pay for all or almost all of the costs for these individuals in the Medicaid expansion population. In addition, there are administrative activities which include enrollment activities in Medicaid, which qualify for at least 50% federal funding, which could help recoup some of the costs associated with those types of activities. In addition, I just wanted to underscore the specific provisions related to mental health and substance use disorder services and medications, again, given the large percentage of justice-involved individuals who have histories of untreated mental illness, histories of untreated substance use disorders. As I mentioned before, there is a lot of flexibility that a state has to design its own Medicaid program, including the types of benefits that are provided. But under the Affordable Care Act, there are some floors that were established. So mental health and substance use disorder benefits were determined to be essential health benefits under the new law, and they are required for those in the Medicaid expansion population. Also, other types of insurance programs on the private side for those plans in the health insurance exchanges and a number of plans outside of the health insurance exchanges. But again, these are required benefits that are now going to be required to be available. In addition, the parity law, the federal parity law, MEPEA, the Mental Health Parity and Addiction Equity Act, which became law in 2008, was extended through the Affordable Care Act to a number of plans, including, again, those newly eligible individuals for Medicaid. So the parity law requires, just as I'm sure you've heard, does require that people who have mental health and substance use disorder benefits, that access to those benefits is not more restrictive than access to other covered medical and surgical benefits. So you would look at the scope of services to see if there's a comparable continuum of care that's offered for mental health and substance use disorders as compared with other types of chronic illnesses. You would also look to the financial requirements that are imposed and the treatment limitations, the medical management tools that are used, and also the day and visit limits that are again imposed on mental health and substance use disorder benefits, to look to see how they compare with other covered medical and surgical benefits. So again, the attempt here is to ensure that people have good access to mental health and substance use disorder care and can access the right clinically appropriate type of care and amount of care. So again, this is critically important when we look at Medicaid eligibility and enrollment and knowing that people, again, who have suffered with mental health or substance use disorders and are coming back into the community from incarceration, knowing that many of those individuals who didn't qualify before for Medicaid will qualify for Medicaid, and knowing that those services and medications can be covered by Medicaid is hugely important, both to the individual's health, but also, again, to looking at the individual's ability to successfully reenter the community, not recidivate, and yes, all of those positive things. So things to do with all of this. All of this is really state-specific. So the first suggestion we would always make is to really examine your state's policies and practices to really understand what happens to an individual's Medicaid status when they become incarcerated. Are you in a state that suspends Medicaid? And if so, how does that work in your state? Or are you in a state where Medicaid is terminated? Are there specific policies and practices that your state Medicaid office has determined related to enrollment for justice-involved individuals? Has your state Medicaid office come up with a process, and what does it look like for a criminal justice agency to become certified to do enrollment activities and to be eligible to get funding back, again, potentially, to cover some of those administrative activities, including enrollment? Understanding really the landscape of decision makers and who are the players in your state and really serving as a resource. This is incredibly important. I think health and criminal justice are working much more closely together now than I think ever before, and there are just huge opportunities that coordinated close work presents to both systems. So I, again, just encourage supporting this coordinated work between Medicaid, between the private health insurance decision makers, community care providers, again, with the key criminal justice and corrections stakeholders and decision makers. Also, again, taking this information back, really learning, again, looking forward to the North Carolina presentation, how certain states have done it, and just the sheer cost savings in terms of federal dollars that states have realized because of this inpatient care exception to Medicaid. And really, again, being able to relay that information, especially if you're in a Medicaid, a state where you terminate Medicaid when a person becomes incarcerated. And again, look at how other states have done this and see what might make sense for your system. Incorporating screenings for eligibility and enrollment processes into your system, really trying to figure out how this might, where this best kind of makes sense and where you can incorporate enrollment in as seamless a way as possible. Looking at intake processes and screening processes and ways to, again, incorporate eligibility screenings and enrollment for people who are eligible for Medicaid. Again, making sure that there is a way to transition, to coincide this with transition planning, even if you are not in a state that does Medicaid suspension while a person is incarcerated, looking toward the back end to determine how you can work with the process of the person before release back into the community, and whether there's a way to time their enrollment in Medicaid to, again, take into consideration when that person is going to be back in the community and to try to really have as little a delay as possible when that person is back in the community. Technology systems, again, hugely important. We know that a number of states have taken advantage of opportunities. There have been some federal dollars that have flowed to states and localities to help states upgrade their systems, and a number of states have really included the criminal justice system to ensure that they are at the table and helping to inform the process and to make sure that, again, the Medicaid enrollment process is not, that the computer system is not a barrier for ensuring that screenings and enrollment happen. And I just would quickly mention again that Legal Action Center with Advocates for Human Potential and TASK are really grateful to have support from Bureau of Justice Assistance, and we are doing work with a number of the grantee groups in the criminal justice system to gauge needs related to the Affordable Care Act and how we can help. We're trying to put out some good informational materials and support folks through different presentations. So looking forward to the question piece at the end. And I will stop there. Thank you very much.
Can and do leverage federal Medicaid dollars to finance health care for their prison and jail population. We now are going to turn to Terry Catlett, Larry Huggins, and Bill Appel to hear how North Carolina has put this opportunity into action. I'm first going to introduce the speakers, and then they'll go through their presentation. Terry Catlett has been Deputy Director of Health Services for the North Carolina Department of Public Safety, formerly the North Carolina Department of Corrections, since March of 2011, where she provides oversight of medical, dental, and mental health care for approximately 38,000 inmates in 61 facilities located across the state. Prior to joining North Carolina DOC, she worked over 20 years for the Federal Bureau of Prisons, serving in various positions, including Health Services Administrator, Executive Assistant to the Warden, and Chief Office of Quality Management in the Health Services Division, Central Office in Washington, D.C. Prior to her career, Ms. Catlett worked in family practice in Philadelphia, Pennsylvania, received her BS degree from Hahnemann, a physician assistance program in Philadelphia as well in 1986. Joining Terry from the Department of Public Safety is Larry Huggins. Mr. Huggins is the Social Work Director and Medicaid Program Supervisor for North Carolina Department of Public Safety. In addition, as a presenter, Bill Appel is the Project Director with the North Carolina Department of Health and Human Services, Division of Medical Assistance. Mr. Appel's duties within the Division of Medical Assistance include overseeing non-emergency Medicaid transportation, health coverage for workers with disabilities, and Medicaid enrollment and coverage for incarcerated individuals. Mr. Appel holds a BA from the University of New Orleans and a JD from Tulane University. So let me turn it over now to Terry Catlett and her colleagues to discuss North Carolina.
Well, good afternoon, and thank you for the opportunity to share this information with you today. I am going to provide a brief overview of the North Carolina Medicaid process for our offenders. We're going to start with how the program started, and then we're going to bring you to where we are today. So I'm going to actually start with the federal law, which was previously discussed. The law 1905A of the Social Security Act prohibits federal matching funds for medical care services for inmates in a public institution. But in 42 CFR 435.1009 and .1010 provide an exception to the definition of an inmate of a public institution for individuals admitted to a hospital or nursing facility with the expectation that the individual will remain there for at least 24 hours. The Centers for Medicare and Medicaid Services has made it clear that the federal matching fund is available for any eligible inmate who becomes an inpatient of a nursing facility or hospital. So let's give you a little bit of history on how this whole thing started. So back in March of 2010, through a random audit from the North Carolina State Auditor's Office, a field worker came to the then Department of Corrections to review inmate medical cost containment. So as a result of the auditor's report, there were deficiencies noted in our system of internal control. They gave us several recommendations. Some of these are on the screen. They recommended that we provide payment based on the following negotiated contracts. For example, with our community health care providers, having a more competitive rate. They also asked us to look at either Medicare or Medicaid rates They also said we needed to look at rates paid under other programs for indigent care, and also taking a look at discounted insurance provider rates. So it's interesting that it was estimated that the department, at that point in 2010, the auditor's office estimated that the department could save $11.5 million a year if Medicaid were pursued for inmate patient hospitalization. And that's very striking because that estimate has held consistent throughout our entire program. As mentioned before with billing, currently our federal financial participation is approximately 70%. Our state match is 30%. And the North Carolina Department of Public Safety pays the Division of Medical Assistance on a quarterly basis. So upon receipt of the auditor's report, the Department of Correction at that time was charged with drafting legislation to implement this program. So in June of 2010, the 2010 Budget Bill, Section Law 2010-21, Senate Bill 897, Section 19.6C, became effective on July 1st of 2010. This particular law stated that the Department of Corrections shall consult with the Division of Medical Assistance in the Department of Health and Human Services to develop protocols for prisoners who would be eligible for Medicaid if they were not incarcerated to access Medicaid while in custody or under extended limits of confinement. The bill further mentioned that the department should seek reimbursement from Medicaid for those health care costs incurred by the department in those instances where an inmate's Medicaid eligibility has been temporarily reinstated due to hospitalization. The bill also indicated that the Department of Corrections should work with the Division of Medical Assistance to determine the feasibility of applying for a Medicaid waiver to cover the inmate population. So prior to the formal implementation and operationalization of this program, the secretaries of the then Department of Correction and the Department of Health and Human Services will enter into a mutually beneficial, comprehensive, cooperative, collaborative memorandum that specifies the individual duties and responsibilities of each department in order to satisfy the special provisions in the Section 19.6C of the 2010 Budget Bill. So the Memorandum of Understanding defines the agency's working relationship. It specifies statutory regulations. It clarifies the custodial relationship of the Division of Prisons with inmates. It defines sharing of information between agencies, and it stipulates the protection of privileged information. So our current partnership was developed, a very, very, very strong working relationship was developed from day one, which was really key to the implementation of this program. The Division of Prisons hosted several meetings which included all the individuals around the table, a multidisciplinary team that was involved in prison health care, Medicaid policy, and HIPAA compliance, as well as all of the information technology personnel from both divisions. And I do want to kind of give you a little note. To date, North Carolina is not an expansion state. So that's an interesting piece of information as we continue through the process. I'm now going to turn the program over to Mr. Appel.
Good afternoon. So, who's potentially eligible among the prison population? The aged, blind, and disabled population, those aged, those 65 years of old, including myself, who refuses to admit they're aged. Inmates under 21. And pregnant women. The requirements are that you be a U.S. citizen, that you live in North Carolina and provide proof of residency, have a Social Security number or apply for one, and be hospitalized in a non-division of prisons facility. When an inmate enters incarceration, they're they're asked about their past or current history with Medicaid. But the key to our program is we have a daily file sharing with the Department of Corrections and Division of Medical Assistance. Division of Medical Assistance receives a daily file of the newly incarcerated and the newly released. DMA compares this with our current enrollment and sends back a file of matches, inmates, matches of inmates and enrolled individuals. The matching file contains identifying information of the inmate's name, date of birth, and social security number. What we are now doing is automatically suspending Medicaid for the incarcerated. We did not do this originally. Originally, we were taking the information we received from Department of Corrections, creating a report and sending it out to the counties. We have a county administered system in North Carolina, which involves 100 different counties. And we found the problem with that is that the counties were not reacting to the files quickly enough, so the suspension of eligibility did not take place sometimes for a couple of months. So we went to automatic suspension, and we still send a report out to the counties for them to check the individuals to see if they're still eligible at all. We accomplished the suspension by using a living arrangement code that identifies the individual as an inmate. And this information is sent from our eligibility system over to our claims payment system, and that living arrangement code prevents any claim but an inpatient hospitalization from being paid. Certain inmates who have Medicaid, when they become incarcerated, they're not going to be eligible anymore. For example, those whose eligibility is because of their status as a caregiver of a minor child who resides with them, obviously are no longer caregivers and are no longer eligible at all unless they fit into some other eligibility category. Also, those who are just receiving help with their Medicare costs are no longer eligible because they're not eligible for Medicare as an inmate. As far as the newly released, they have their suspension lifted and still eligible, again receive full Medicaid coverage. I'm going to turn this over to Larry Huggins now.
Thank you, Bill. It's Larry Huggins. I'm going to review the Medicaid application process. Medicaid applications for inmates potentially eligible are completed utilizing Division of Medical Assistance guidelines as outlined in the North Carolina Medicaid Manual. We review every inpatient hospitalization at an outside hospital using a utilization review process, which is a narrative that includes the diagnosis, the procedures involved, and prognosis. We look at the past medical history from our records. We use the same criteria for eligibility that's used for any other North Carolina state resident. DOP sends Medicaid applications and signed authorizations to the county DSS in the county where the inmate last resided. In the case where an inmate is from out of state, the county of arrest would be used as the last county of residence. DOP social workers are trained to pre-screen inmates so the applications are not made for inmates who clearly do not fit an eligibility criteria. Our social workers routinely have done applications for disability through the Social Security Administration and Medicaid Act. If an inmate refuses to participate or withdraws from the process or is unable to participate in the process, The application continues to be completed. DOP may complete the application as a responsible representative of that inmate via prior agreement with DHHS. We are the authorized representative for our inmates. DOP sends 1 year of medical records and supporting documentation along with the application for Medicaid for the disabled. Applications are made retroactively following an inpatient hospitalization. We have 3 months from the date of the hospitalization to submit that application, and we usually get an ongoing suspension that equals around 12 months. Due to DOP's custodial relationship with inmates, there is no HIPAA impediment to sharing personal health information with the Division of Prisons. When the daily file from DOP indicates that an inmate has been released, the inmate automatically reinstates Medicaid benefits. Full Medicaid coverage is effective the first day of the month of the release date. This has alleviated our responsibility to apply for benefits for our most severely involved inmates at release. Okay, I'm going to go over some program statistics. We implemented our Medicaid program on February the 1st of 2011. We hired 4 additional staff, and those staff are paid for through our general fund. At the end of the first year of operations on January 31st of 2012, there were 550 unique eligible hospitalizations. A follow-up audit occurred in May of 2012, and it showed that North Carolina saved approximately $10.8 million. Obviously, the program was successful. The average estimated savings per hospitalization was in excess of $18,000 per hospitalization. From February 2011 through November 30, 2013, it is estimated that North Carolina Department of Public Safety has realized in excess of $34 million savings, with 1,908 eligible hospitalizations at that time. This statistic shows how we've improved in terms of the success of applications we've submitted. In the first year of operation, 70% of all applications were approved. Last fiscal year, we had a rate of 80% approval. In terms of the total number of hospitalizations, those that are approved to Medicaid and those that are regular pay, for the first year we had 45% eligible for Medicaid. In last year of operation, 51% of all hospitalizations were Medicaid eligible. As of May 31st, 2014, there were 2,228 unique Medicaid-eligible hospital stays. Current cost savings per month as compared to prior non-Medicaid costs have been estimated to equal approximately $1.3 million. And that's, as I say, that's a per-month savings.
Thank you, Bill and Larry. So, since the implementation of our program in February of 2011, we have saved over $40 million in a little over 3 years, which, again, as Mr. Huggins indicated, is a little over $1 million per month of savings through processing Medicaid-eligible applications. With that, I guess we can open up to questions or turn it back over to Dr. Osher for any other comments.
Thank you, Carrie. Thank you all presenters. We will move now into question and answer session. We've had a number of questions already submitted, which the panelists will be fielding. So you can continue to submit questions in the Q&A box in the bottom right-hand portion of the screen throughout the discussion. So I'll try to direct them, but any of you that wish to answer, please do so. There was a question that came in about North Carolina's experience with providers, and that there was an earlier slide that suggested that the different rates and different rate payments be explored. Have the providers accepted the switch in your reimbursement rates to the Medicaid rates that you currently are collecting on? What's that experience been like?
Initially, there were some growing pains, but currently we're not having any issues with providers. Eligibility, determination of eligibility and the flow of information is an issue, but that's improving as well.
Every time we have a new provider, we kind of just remind them of the 2010 law that was enacted, and that pretty much clears up any concerns or questions that they might have. We reference that law on a regular basis. All of our new contracts actually have a piece of that law written into the contract, so there are no questions or concerns from the provider when it comes time for payment.
Terrific. Question here that you in part addressed, I believe, was, can we back bill Medicaid for inmates? This is retrospectively. And if so, how long can you go back? How many years can you go back? You had mentioned 3 months, but didn't know if that was
we can go back 3 months from the month of application.
Okay. And was that a state sort of period that was defined, or is that federal regulations that says 3 months? Okay. Great. Thank you. Is it possible to release the prisoner jail inmates to secure alcohol and drug treatment that would then be covered by federal Medicaid dollars? I think, Gabrielle, that may be for you.
Sure. So I guess the first thing I would question is the secure piece. So if the person is still determined to be an inmate of a public institution, if they are not able to leave that place, if they have to sleep there, that also would be considered, again, to be a public institution, and you would be dealing with the same issues as a prisoner jail. If that person, when you're saying secure, if you're talking about a residential addiction treatment facility that's not connected to a prisoner jail, that could be a different story, but then you run into an issue with the IMD exclusion, which is a person who's deemed to be someone who is in an institution for mental diseases, which includes a residential mental health facility or a residential addiction treatment facility. If that's over 16 beds, then federal Medicaid dollars are precluded, again, under a different part of Medicaid law. So it's very tricky given, again, that every state looks a little bit different. But, again, if a person is still considered to be an inmate because they can't leave a place again, then you have, again, the same problem as if the person is incarcerated in a prisoner jail. And then the second piece, again, there are some specific Medicaid policy prohibitions for federal Medicaid dollars in a residential treatment facility that's over 16 beds.
Great, thank you. There's a question that about the challenges associated with suspending rather than terminating, and I think, Deborah, this goes to you. I know that you had stated that federal guidance is to encourage suspension versus termination, but we've also heard that some communities get paid for the identification and termination of individuals, a small amount of money for that particular procedure. How do those two sets of policies reconcile themselves, and how does that apply to the discussion that we're having today?
Sure. So I think we are at kind of a turning point. I think, again, this is the inpatient community-based exclusion provision is becoming more and more understood, and I think driving a number of states to make changes to their laws and their policies and practices to be able to, realize these savings and ensure that people who are eligible for Medicaid can be enrolled in Medicaid and can maintain that status. I think there will be some time to figure all of this out, and I think as states kind of work through the state waiver process and work to amend their state Medicaid plans, that they can kind of take advantage of that time to really examine how their criminal justice involved population, how their Medicaid policy really squares with their justice involved population. And I think we can also expect at some point there, in light of the Affordable Care Act and, again, different policy changes around the country, there may be additional guidance that the federal government issues to clarify some of these things.
Okay, thank you.
Sure.
Probably back to you, Gab, again, with a question about ways in which organizations incorporate eligibility screening into their correctional processes. And is that best achieved at booking? Is it best achieved at reentry? And then I'm going to add a third component to the question that came in. Have participating states been asked to provide birth certificates with Medicaid applications for people over 65? It's a specific question, but the general one is, what are the ways in which correctional facilities have been screening and determining eligibility for Medicaid within their offender population?
Sure. So I would say a lot of states have been doing different things. I think the states that do have very clear policies that allow a person's Medicaid eligibility to be suspended, a lot of them are looking at incorporating at booking and really as early as possible screens to determine whether the person is eligible, to determine whether the person is enrolled in Medicaid. Then I would say there's a whole other group of states who are really looking first to try to time eligibility screens and enrollment with discharge, and again to try to decrease the lapse between people being released into the community and their health care coverage, to really try to ensure that there's good continuity of care. We also know, at the very front end of the system that there are a number of states that are trying to use community courts and really, really front-end opportunities to try to divert. And there also are opportunities, again, in the community through community corrections to screen and to get eligible people enrolled. I would say at every kind of intercept of the justice system, there's work in different states on this. On the question of Medicare and birth certificate, I really can't speak to that. I'm not familiar with that, so I don't know if there are other folks who are listening who've encountered that. But I know on the Medicaid side and also with private health insurance eligibility, the federal government has tried to make this much less burdensome than it has traditionally been to try to determine whether the person is eligible for health insurance, whether it's Medicaid or other types or private insurance. But I know that we do hear sporadically of concerns where in certain places they're asking for additional information that may be difficult if the person's incarcerated or kind of disconnected from different services to be able to access those things.
In North Carolina, we screen at processing. We do a daily matching of numbers, and we review each and every hospitalization to see if the inmate may be eligible. As far as birth certificates, we do not submit birth certificates.
Great. There's a series of questions that relate to who does the actual eligibility screen and what steps are necessary to take at the department level, and is it necessary to classify a corrections employee as an official or authorized representative of the Medicaid system? And I'm looking for some help from North Carolina, who has done this. A related question, and we'll package this together, is, do you know of jails or prisons where correctional officers are being trained as certified application counselors or navigators to engage and educate inmates in the opportunities afforded by insurance, either through the ACA or otherwise? So a series of questions about who does this, what kind of training do they need, what authorization might they need to be actually screening and starting the application process.
Well, first in North Carolina, before we even started this program of covering inpatient hospitalizations, the Department of Corrections had a long history of submitting applications for inmates who were about to be released. So they brought that experience to this program. Let them answer, but as far as I know, there's no certification. It's just some training, and that screening is not the kind of screening that comes when an application is processed at the county level. It's just a very broad screening.
That's the issue about having correctional officers certified as part of to assist as navigators. We're not part of that process. You know, we're not an expansion state, but I do know that we can certainly, I can get some information from the American the ACA, American Correctional Association. We have a national listserv where I could put a question out to several of my colleagues across the United States, and I'm sure I could get a response rather quickly from those states who do possibly have that process in place, but for the most part, I know we do not have officers acting in that capacity as navigators, again, because we're not an expansion state.
Mm-hmm.
But I could certainly find that information out, again, from colleagues that I have through the American Correctional Association.
And this is Deb. I would just add that if the enrollment activities, if the intention is to try to get some reimbursement, some federal dollars to cover some of the activities, the administrative activities, a state Medicaid office often comes up with a policy and kind of the procedures that govern how that works. If it's a matter of helping an individual enroll and that's just kind of a part of the way the system works, there are often less kind of prescriptive requirements there. So again, kind of the money hook is a big part of how some of this works, I would say. And again, it's very state specific in terms of the way the Medicaid office approaches it.
Thank you. There were a couple questions which in part were answered during the presentation about how did you get folks to do this, North Carolina? How many did you need? Are you hiring more of them? And what are the ways in which staff can actually be supported in the enterprise of identifying folks going forward? Could you talk a little bit about the staffing patterns that you've employed to promote your program activity?
Okay. We hired 4 additional staff to work on the division level with the program. As far as on the facility level, we utilized the social workers who were already in place. As been mentioned, our social workers have a history of doing Social Security applications and Medicaid applications. They understand the processes. So it was just an add-on to their duties. And one thing I mentioned earlier, if an inmate goes in the hospital, he's released, and we've got Medicaid on that individual. Once he's released to the community, it takes care of doing those apps, and we don't have to make that part of our process for release. It basically helps the system.
Mm-hmm.
And again, the law that we drafted, or the bill that we drafted that was passed into law, certainly is what's been very instrumental in the success of this program. If that law was not in place, I'm sure the providers in the community certainly wouldn't be on board as they're required to today. So the legislation that was drafted was really critical to the success of our program.
Interesting. There's a question here that I'll throw out. I'm not sure I understand it entirely, but is there any reason why a private corrections company would not be able to bill Medicaid for qualified inpatient services?
Not to my knowledge.
They're not representing the state. They're representing the private correctional organizations are not necessarily representing their state. They're for profit. We're a nonprofit organization, so therefore they would be ineligible for that.
At the very least, there would have to be an agreement, a contract between the state Division of Medical Assistance and that entity just to allow the flow of infected health information back and forth. Beyond that, I think there's a legal question involved that's beyond our knowledge.
We've got a few legal questions here, and we might sort of have to defer on some of them, but let me put them out because the audience is interested in this. And that is, one is, are other states collecting application information and signing applications without the assistance of the inmate? Our department has concerns regarding the inmate's federal right to privacy.
Well, we have an agreement with DHHS that allows us to be the authorized representative for the inmate. And if the inmate refuses to cooperate, we are still allowed to complete those applications. As far as confidentiality, when it's possible and when the inmate's willing, we obtain releases of information for DHHS and the Division of Disability Service.
You have to keep in mind, too, that correctional facilities are HIPAA recognized entities because in the course of doing their business, they are the custodian of inmate medical records.
There are times when the inmate does not have the capacity to complete or sign the application. Therefore, we are the representative of that individual to Department of Health and Human Services. A lot of times you have, demented patients or those who may be incapacitated for whatever reason, and therefore at that point they don't necessarily have, again, the capacity to complete the application or sign the application. Therefore, we do have the authority to do that in their behalf.
Okay, great. Thank you. Here's another legal question. I work in Colorado at a community corrections facility. I have clients who go to the ER for less than 24 hours and get enrolled in Medicaid. Can they face charges for fraud using federal dollars? Does anyone want to answer?
Well, I guess I would first venture, again, kind of a question about that type of facility, if it's community corrections. If the first question is that person an inmate of a public institution? Can that person go home? Is this a situation where the person is, there through some kind of work program during the day, but then has freedom of movement? Then that person, again, wouldn't be an inmate of a public institution and should be able to have Medicaid coverage. But again, it's a question of the status of that place and how that works. And I guess that's all. I'll just start with that.
Mm-hmm.
Yeah.
Okay. So a lot of thorny legal issues get raised to discuss these issues, and we're not on the final word, but we really appreciate our panelist experience. There's a series of questions that have come in about whether these rules that we've been discussing in the inmate exclusion applies to individuals being held in county jails. or is it just applicable to DOC folks? And then following that, then, is there any distinction between individuals that are on pretrial status versus sentence status while they're in those jails? And then beyond that will be a little bit more from North Carolina about their experience, mentioned briefly in the presentation with moving this program from state prison to the county jail. So maybe Gab, start out with just a general response about the application of Medicaid regs to county jail versus a state prison population.
Sure. So yes, county jails would be included in that definition of a facility that would be covered, and again, a person could receive care out in the community for over 24 hours at one of those different types of facilities we talked about. So it's not limited just to states. The second piece, I believe, was on coverage for an individual who is there pre-adjudication, being detained before sentencing. And this is an area with Medicaid law, unfortunately, Medicaid does not kind of follow that person. This is an area where if a person has private health insurance and they're being detained in a facility, then they aren't automatically kind of kicked off their private health insurance. But this is a case where with Medicaid, again, Medicaid dollars would not be used to pay for that individual. Yeah, so I'll just leave it there and let the North Carolina folks talk about their piece here.
Well, the success of our program kind of got out. The North Carolina Sheriff's Association, kind of asked us to assist them with their applications. So as a result of our success, there was an addendum to the bill that was signed by our governor at the end of last year that pretty much advised that North Carolina Department of Safety would work with the North Carolina Sheriff's Association, and the law was passed, and it actually becomes effective July 1st. Where the counties now will go through the county jails will now go through the same process as North Carolina Department of Public Safety in order to process applications for their offenders. So we were so successful, we now have been given the responsibility to reach out and help our county jail partners in this endeavor. And again, that law was signed by our governor, I think it was August of last year, to go into effect July 1, which is right around the corner.
Great. Thank you. A few questions specifically on the data that North Carolina provided, and it was one that sort of asked about the savings that was presented, and did that savings, which was accrued to North Carolina Department of Public Safety, incorporate or include the expense to the state for inpatient care? So that the question is, did the federal participation in the services outweigh the state expenditures that still are necessary for some of the Medicaid inpatient care, and was that factored into your numbers?
Sure, there's a cost savings. As far as Division of Medical Assistance goes, it's essentially revenue neutral, except whatever admin is involved in it. But for the state as a whole, it's certainly a vast savings.
Mm-hmm. So the numbers represented not just the DPS savings, but the statewide savings. Is that correct?
That's correct. That's correct. The positions that were allocated for this project were full-time equivalent. That money was factored into our annual budget, but again with a reduction of approximately $13 million a year, the administrative costs are right around $150,000 for staff. So in the big picture, we're still looking at approximately, $12.5 million a year or so in savings to the state of North Carolina.
Mm-hmm. There was a question that came in related to the chart that you showed with individuals with inpatient stays. Roughly 50% of them were approved and 50% were not. The question was, what were the reasons that the inpatient stays were not approved? What were some of the reasons?
The basic reason is those individuals would not have been eligible for Medicaid. They wouldn't have fit the criteria. Yeah, they may have had too much money. They may not have had an ailment that would qualify as disabled. So we would not have applied for those individuals. And some we've applied for may have been determined to be ineligible, but we're running at 80% approval for the applications we send in.
And for example, if the inmate has more than $2,000 in his or her account, that makes them ineligible. So we have to look at the entire picture of, the inmate, his or her history, medical history, and their equity, which makes them ineligible. They may be eligible from the sense that their medical condition provides eligibility, but because they have more than $2,000, then that makes them ineligible. And we wouldn't know that when we first, start the process.
Thank you. There's a sort of a quicker one. How long did it take North Carolina to implement their cost containment program?
Well, we received a report, and within a matter of 90 days, we had put a program together. So the report was received the auditor's report was received at the end of 2010, and by February 1st of 2011, we had the program in place. So it was a little less than 90 days.
Well, we met, I think, on a weekly basis for a while, and developed a really good working relationship out of that process, which continues to this day. So whenever there's a problem with a claim or a question about whether a case was processed correctly, we communicate with each other and work out the problems.
Terrific. Thank you. Kind of moving down and running out of time and questions here, but one came through that was asking what the level of coordination or IT solutions are that's needed to ensure corrections and Medicaid communicate well, and that the individual's enrollment status is properly documented. So without getting too much into the weeds about information technology, what is the way in which that can be best coordinated, and what examples exist, either Gab or North Carolina?
Well, the key for us was the daily file transfer and the automatic suspension, and then having the counties follow up. But the automatic suspension prevents fraud from Medicaid cards of incarcerated individuals being used by other community members. And it saves Medicaid from paying for claims that shouldn't be covered.
And I guess I would just add, again, kind of it's hugely important, and I think being armed with this information about what certain states have done and the cost savings that have resulted, and that these things can happen. I know my office is based in New York, and the technological barriers were often cited as reasons why they couldn't suspend indefinitely, but they were able to, again, identify the cost savings opportunities and be able to really push the state to develop systems that would allow Medicaid to be suspended indefinitely. So I just would say that, again, I think the North Carolina example is incredibly helpful in looking to other states to see how they've done it and what they have used as data to really show the state that this is possible and, again, will really help in a number of different directions.
And again, we're a county-administered system, and we have 100 counties. If it was a state-administered system, it could probably be automated to a greater extent.
Mm-hmm. Some challenges that people have found their way to overcome and circumvent them. Look, and I'd like to really thank all of you for participating, and special thanks to Gabrielle, Terry, Larry, and Bill for their presentations. We also, at the Justice Center, would like to encourage you to sign up for our newsletters by clicking on the subscribe button at the top right-hand corner of our website. And that will then sort of provide extra information on this topic and others related to effective responses of individuals that are in our criminal justice systems at this time. After you exit the webinar, a brief survey is going to appear on the screen, and by answering the questions in the survey, you'll really help us and help the Resource Center improve the services we offer. We greatly appreciate if you take a few minutes to complete the survey, and I thank all of you for taking time out of your busy days, presenters, panelists, and participants alike, to focus on this important topic. Hope it's been of help to all of you, and I wish you all a very good afternoon. Thank you.